Good afternoon or good evening if you are on the East Coast. So welcome to the highly anticipated professional learning series titled, What is Cerebral Palsy? A Neurologist's Perspective. This series is hosted by the UCP Research Council and sponsored by UCP of Central Arizona and Gillette Children's. These series are a testament to our commitment to education and to research. UCP's extensive network comprising of 54 affiliates in the US and 2 in Canada that provide vital service to over 150,000 children, teens, and adults annually. Why do I know this? Because if you don't know me, I am Armando Contreras. I am the president and CEO of UCP. UCP is highly committed to research that transforms care by infusing evidence-based practices. In the past 4 years, the members of the US UCP Research Council has been invited to speak on this impactful research throughout the nation, and also they've received international invitations. Today, you will hear from Dr. Tim Feyma. However, before his introduction, I'd like to turn it over to Valerie Piercini, Vice President of Clinical Operations and Innovation. She and Dr. Michael Kruer also co-chair the UCP Research Council. So with that said, enjoy the series today. Thank you to the speakers, to our guest speaker, to the sponsors, and Valerie, take it from here.
Thank you, Armando. Welcome on behalf of the United Cerebral Palsy's Research Council. I want to thank everybody that's attending the professional learning series. I'm excited that we have a lineup this coming year and also starting into 2025 of some great speakers. I am Valerie Piercini, as Armando said, and I am here from speaking to you from Phoenix, Arizona, a United Cerebral Palsy of Central Arizona. So today's presentation is, as Armando said, a collaboration between the Research Council and Gillette Children's and United Cerebral Palsy of Central Arizona. Today's speaker is Dr. Timothy Feyma, and he is an Associate Medical Director of Gillette Children's Neurology and leads the Gillette's Movement Disorder, Rett, and Motor Delay clinics. He has active research endeavors ongoing into movement disorders, cerebral palsy, and novel drug research for orphan diseases. Dr. Feyma is board certified in epilepsy and neurology. We're very excited to have him today. And before he gets started with today's presentation, I just want our attendees to just be aware that the meeting is recorded. We will not be taking presentations during the meeting, but in fact, you are welcome to post those questions by clicking them into the chat. The live Q&A will happen we'll begin immediately after today's presentation as well too. And as far as your continuing or your CMEs, for tracking purposes, it's very important so that we can get those CMEs to you, that you use your full first and last name. You can see in my screen down below my full name as well as my location. That will help us to be able to get those certificates to you. So please help us make it easy and put your full first and last name. Now, for no more delay, I want to turn it over to Dr. Feyma for his presentation for today.
Thank you, Valerie. Let me just share my screen 1 second here just to make sure everything is going to work. Can I just get a thumbs up or a verification that people can see my slides, if that's okay? Yeah, thank you. Okay. So I appreciate everybody giving up time. I think we have lots of resources, and certainly as time goes on, one of my most valuable resources is time. And so for those on the East Coast, this is late. For those in the more portions of the US or Canada for that matter, if they're here, this is earlier. But it takes a lot to kind of block time to come to some of these talks. And I picked a very large topic so I could sort of meander a bit. I have a purpose to that, but I tend to start big with most of my talks and then focus in sort of what's my point at the end. And so My understanding is this audience is a mixture of therapists and providers, and probably some parents as well. So some people I'll give way too much information, some people won't be enough. So hopefully I can hit the broader population with the topic overall. I want to first say that I am a speaker for PTC Therapeutics. I prescribe no meds for that company, but I'm working on some of their product development, and I do speak for KD Pharmaceuticals. I do prescribe DAYBUE for Rett syndrome, but that's not the focus of the talk today. So neither one of these should impact my presentation today. I purposely picked a very large topic overall. I came to Gillette in 2009. I came from Seattle Children's, and my experience in training was cerebral palsy patients we saw now and again. And then I came to Gillette, where probably 50% of my practice was cerebral palsy. And my practice in the last 15 years has sort of seen the development of a lot of changes in medicine. Neurologists, we tend to be part developmental pediatrician, part neurologist, epileptologist, part geneticist, part becoming more PM&R in orthopedics as well. And so my evolution and understanding of cerebral palsy has happened along with multiple developments in the community as well. And Dr. Crew has mentioned already, he's one of the lead investigators for some of the genetic underpinnings of cerebral palsy. We'll talk about a bit too. So I'd like to talk about the history of the term cerebral palsy. I'd like to talk about kind of the heterogeneity that we're learning that cerebral palsy is and some of the quote unquote mimics. I have a fascination and kind of like and dislike for that term, but we can talk about that more. And I want to understand that, it's good to understand the history of cerebral palsy, understand sort of what the heterogeneity is, but most importantly, practically, how do we help patients? So when I run clinics for newborns, where we try to see patients with motor delay, I say to parents early on, our focus is twofold. Number one, why is this happening? And the second is, how do we help? That's really all we do. How we get there sometimes can be very complex and can be require a lot of education. So I am a big picture kind of person, so I tend to really start with the really big picture overall, and I tend to dig into history. I'm kind of a history buff / geek, and I'll own it because I love it. And I think cerebral palsy is not new. It's been around for a long time, and there's even this beautiful paper that came out and it detailed the overall history, where they're talking about some of the pharaohs in 1196 BC, or some of the stela from the goddess Astarte in Rome from 1580 BC, to even some of the Emperor Tiberius Claudius Nero from 54 AD. Too, he had tremulous. And if you look at the far left, there was an evidence of kind of a foot that's very deformed, and you think that there's probably an upper motor neuron lesion causing that. In the middle stela, you can see there's an actual old version of what would be sort of a crutch of sorts. And so and in the far right, the emperor, I can't really highlight that with the picture, but what I will say is he was known for having, quote, tremulum, and what sounds like probably was aphthatoid cerebral palsy. We certainly can't look backwards and know what was the case. What if it was a spinal cord cyst, or what if it was a weird sort of variant of a polio type syndrome? We don't know that. But whatever the case is, we talk about cerebral palsy like it's this modern thing, but the thing is, these definitions, this awareness sort of evolved over time. And CP really sort of made a leap forward in the 1800s with William John Little. And he was a physician that trained at the medical school in London and really found fascinating some of these the cerebral palsy diagnoses. And so he actually wrote a treatise on the deformities of the human frame. And he was one of the first with some of the doctors in Germany to do some of the club foot surgeries. And so there's some fascinating information on that time. Actually, Sigmund Freud had a role in sort of defining, he had a hypothesis that a lot of cerebral palsy was related to birth injury and not congenital brain abnormalities. But there was a lot of debate then, and to be fair, there's lots of debate now, which I'll talk about with what cerebral palsy is. But it was the empirical age, sort of in the 1800s, where they really began to figure out, okay, we're looking to what is causing these unique neuromuscular conditions, the deformities, the tightness, the spasticity. And so I'm not going to dig through year by year, century by century, but I think the 20th century, we've seen previous to this, we saw a lot of development with developments of physiotherapy in children, constraint-induced movement therapies, orthopedic innovations continue to develop, Botox for focal tone management or more generalized tone management, intrathecal baclofen rhizotomies, whether it's selective or even now more non-selective, are being done, and then braces assistive technologies, and then even adaptive technology as we continue to dig into kind of what we can do to help these patients more than just surgical, because it's it's a lifelong. There's a lot of increasing tools in the toolkit that we can use to help. And there's a lot of promise for the future, whether it's brain stimulation or even other developing therapies and exoskeletons and all that stuff, right? So I'm very hopeful. We've come a long way in the last 100+ years, and I hope we can go even further in the next 100+. So, and who knows, the promise of stem cell injections and things like that, what that impact that might have to benefit our patients. And so, the 20th century also brought us more understanding of what CP is, of the etiology. So the treatments are one thing, the understanding has been deepening as well. And so, we've come a long way since the early 1919, when this is a pneumoencephalogram. They would inject air into the brain and take an X-ray, look at the brain itself, to nowadays where we have these MRI machines that are amazing. And the picture on the right is meant to highlight that our MRIs are getting better. MRI magnet strengths are measured in Tesla. This is a 1.5 Tesla compared to a 3 Tesla compared to a 7 Tesla. It's the same brain. And as time goes on, our technology improves, we get smarter. We are learning so much more all the time. And I could even talk about diffuser tensor imaging, but I'll stop there just to say that we are getting better. So cerebral palsy, we learn more about it, so we're getting smarter about it. So when we think about cerebral palsy, I think I'm going to use a kind of a really basic, typical sort of kind of case that we tend to see in clinic. And this one is a patient of mine, Natalie, who is an 11-year-old. She was first-time mother, 41 weeks gestation, just term, and pretty much uneventful pregnancy until she was born, needed help with resuscitation at birth. I'm keeping the story very trim because I don't like to have overly busy slides on purpose, but she went to the NICU. She had some neonatal encephalopathy that matched with her hypoxic ischemic injury. And this is her brain on the right. And if my cursor can be seen, she has some diffusion changes in the kind of tail of putamen here, the basal ganglia. There's a little bit in the thalamus as well. So this is a term hypoxic. Term hypoxics tend to have selective injury to the deep structures of the brain if it's a very mild hypoxia. And they have really hyperkinetic movement. She's dystonic. She's a bit spastic. And she's also a little bit hypotonic centrally. So she's one of our mixed tone cerebral palsy patients that we see. So cerebral palsy is easy, right? We just get the MRI and we see that it's a brain lesion, right? This is another one of my patients actually, too, who was more of a hemiplegic. This is right brain injury, so he's a left hemiplegic. And so it's really easy to define what cerebral palsy is, right? Obviously, I'm going to make this somewhat controversial and sort of dig into that because I think it's not that easy, and we're learning more universally it's not that easy. Even in my first year here, 15 years ago, I saw patients that were cerebral palsy but had normal brain MRIs, and it was digging into that sort of mountain of kind of this doesn't make sense. That's informed my career at my time at Gillette and the thousands of patients that I've seen. So, my education as a neurologist has been what is cerebral palsy, and even in our texts, and I love the ACARD text. Jean ACARD was a really superb writer, French pediatric neurologist, who said, cerebral palsy is a socioeconomic medical framework for certain motor disabled children with special needs. It does not describe a single disease entity, but rather a collection of disorders with different etiologies. So even from the beginning of my field and my practice and my career, we still haven't really pinned down exactly what it is. And so highlighting another definition using the AAC-PDM, I mean, even then they talk about this is a development of movement and posture, activity limitation, non-progressive disturbance that occurred in the developing fetal or infant brain, often accompanied by sensation, perception, cognition, communication, behavior, epilepsy, and secondary musculoskeletal problems. So again, it doesn't really go into etiology fully because I think all along with increasing awareness, there's been awareness that there's a mixed bag. And so it's not really an etiologic diagnosis, but it's more of a clinically descriptive term. And I'm using some of the definition classifications that were devised back in 2006. There's other definitions too. We could talk about the American Academy of Pediatrics. I could dig deeper, but I think those two definitions sort of like, we know it typically is not progressive, typically affects neurologic development, and typically we don't think of it as progressive overall. And there's been many attempts to try to kind of define what cerebral palsy is, whether it's dysplastic, dyskinetic, ataxia, complicated, mixed. And I'll even say that this is one very simple graphic. I wish it was this simple. It's usually not. This doesn't even capture some of the paraventricular leukomalacia premature births that are like born at 27, 28 weeks, where they do have sort of a mixture of spastic dystonia. And this even misses some of the other sort of registries where they've actually highlighted things like what is hypotonic CP. Cerebral palsy as a term is a very diverse term, and it includes a lot of different movement disorders, and it can be very challenging to define. So we know that, and we're getting smarter about that. And there's more literature that's coming out on that. And I think that there's probably some people on this call who are authors of this study. Dr. Kruger, we mentioned before, and Dr. Aruba Muthan at WashU in St. Louis, they started to dig into this a bit. And this excellent paper from 2021 looked at 4 scenarios and actually polled physicians and says, is this CP or not? There was one case where it was pretty clear non-progressive spastic CP. If you look, 96% would diagnose CP. The second case was sort of more progressive, very clear case of genetic, but they gave 2 other scenarios that weren't quite as clear. A little bit of premature birth, a little bit of progression, non-progression, and it was just very confusing. So the doctors can't always agree exactly, is it typical CP or is it not? Because there's so much for the neurology community that falls in the gray zone, and we're aware of that. So when do we say it's CP? When do we not say it's CP? And I think that we could sort of say, are some of these things cerebral palsy mimics? I'd like to highlight again some of Dr. Kruger's work with others when he published this in Nature Genetics. He showed that there were definite areas in a pool of cerebral palsy patients where there's enrichment of some unique genes that could be associated with culprit as culprits for causing some of the CP or being associated with risk for CP. The question is, we see this with concussion. Some people get lots of concussions and recover quickly. Some are very vulnerable to concussions. So are there some kids that maybe are just vulnerable to a mildly abnormal birth and maybe are more likely to get CP? So is there kind of the risk genes that we need to be mindful of? But it's also been looked into with other studies as well. There was a study by Yetchieli, this is out of Jerusalem. They looked at this in 2021, where they looked at kids with cryptogenic cerebral palsy, meaning kids that seem to have normal brain scans and but they seem to be more impaired than the brain scan. And they tested the kids with whole exome sequencing and chromosomal microarrays, and they found that 26 of these 45 kids tested with kind of typically brains, they found diagnostic yield of genetics in 58%. And so and I say there's even other studies too that even because of the typical brain scans that maybe look like a little bit typical CP, we are finding genetic mutations in them as well. So I think the genetics is making things a lot more complicated for this and for all. We're seeing, we think about genetics, we think about, it's challenging because the example I use a lot is, Down syndrome. We're not here to talk about Down syndrome today, but Down syndrome is a potential list of 40 symptoms or manifestations. Some kids check 2 of the 40 boxes, some kids check 38 of the 40 boxes. And so, we're learning that with cerebral palsy. I've had a couple of kids I thought were just typical classical cerebral palsy, did some testing, and boy, did it surprise us. And so this slide is meant to overwhelm because, they've even done some studies. This is a paper from Neurology back in 2020. They were talking about sort of like what could be looked for in cerebral palsy as genes, and this is actually not even a complete list now. It's missing some even some other issues that I think about. But the problem with genetic testing as well, though, is we go down that path, and so I'm actually going to show a de-identified gene test like what the doctor gets for those that aren't in the medical field. What we get behind the scenes when we do this is an idiopathic cerebral palsy panel. So this is a gene panel of 400 plus genes to try to figure out it's a child that looks like cerebral palsy, brain scan looks normal. So we test them with this gene panel of 400 plus genes, and we get something like this back. And this is actually a normal study, believe it or not. We get these variants of unknown significance. So, and there's one kind of benign pseudodeficiency allele, but it can be very confusing because when you begin to wade into genetics, we find lots of curiosities that oftentimes aren't causative. And so it gets complicated. And since genetics is still evolving, we may find things that, we are still learning, is it normal or not? And we might find something in a child looks like it might be the issue, after we use some of the prediction models and some of the fancy testing and sort of analysis we can do, and then we'll test parents. And sometimes we'll figure out, oh yeah, this really seems like it's the case. Now the parents have it, this child has it, it's predicted to be very pathogenic. Other times we still end up on a road to nowhere. We do all the testing, and we still don't know because genetics is still evolving. And in the epilepsy field, which we're not here to talk about today, right now they currently recommend that you update epilepsy testing, gene testing, every 3 years if you suspect a genetic cause. So genetics is evolving that fast that every 2-3 years, the body of scientific data may advance to a degree where it's useful to re-examine something if it seems genetic and we don't really have a crystal clear idea of what the cause might be. So I think that we're getting there for cerebral palsy, movement disorders, and a lot of other conditions as well. And so I'm moving kind of fast, but I'd like to kind of back away from this and just give a couple of patient examples because I find my passion more in talking about patients anyways, as I hope most of us do. And so I'd like to start with one case study because I think that this highlights 2 very different paths for 2 patients of mine that I've cared for, one for a very short time, one for a very long time. And so I'm going to highlight OK and CM, or as I know them, Ollie and Colin. Take a drink for 1 second, I apologize. And so obviously they're related, that's why I'm presenting them together. But I'll talk about Ollie first. So Ollie is a 13-year-old male with a history of early diagnosis hypotonic cerebral palsy. He's one of the first patients I saw when I came to Gillette. And from the beginning, his brain didn't make sense to me. He was called cerebral palsy. I just was like, it's just something seems off here. And he never sat, never crawled, severe hypotonia. And around the age 2, he developed really bad focal epilepsy. And then just for fun, he threw a movement disorder in as well. So hypotonic, delayed, chorea, the dance-like movements, that's the Greek word for dance, and then epilepsy. And before his diagnosis, I did 6 MRIs because I cared for him over many years. And as a neurologist, that's what we do. We don't find a diagnosis, we repeat stuff. And numerous metabolic labs. I'm happy that when I started my career 15 years ago, we did lots of metabolic screening. A lot of times that would trend towards genetic testing, but now we sometimes will just skip the genetic testing because the metabolic labs can be fickle. To be fair, genetics can be fickle too. I even did spinal taps with neurotransmitters and looking for glucose transporter 1 deficiency. I did a muscle biopsy on him. I did 2 nerve biopsies on him. I did a karyotype and CGH array before I could do more testing. And then for about 5 or 6 years, the family said, no more testing. And I said, got it. Because that's also, I follow the family's lead. I always offer everything. If they say, I want to take a break, as long as I educate them and say, we may find something, we may not, I'm okay taking a break if their life's been medically intense. Compare and contrast that to Colin, who he was a 23-year-old, long diagnosis hypotonic CP, never sat, never spoke, crawled with hypotonia, developed focal epilepsy at age 2 plus chorea. Kind of sounds familiar. His last MRA is at age 2, so he had been, like a lot of my adults, because I do care for adults, they sort of missed the genetics revolution. They've missed a lot of modern medical workup. And so there's very fertile grounds for diagnosis in my adult clinic because it's just a lot of them are head scratchers and they can tell you a lot. He had metabolic screen in the past that was normal, but no genetic workup prior to my first time I saw him when he was 17. And let's not just talk about Ollie and Colin, let's meet them. So this is the 2 patients. This is Ollie at a much younger age on the left. He's going to be kind of a collection of his videos all together, and that's Colin on the right. This is actually when he's in his 20s. This is after diagnosis, because I asked both their parents if I could use their videos, and they both said yes. Please play just for a second, just to give some idea, because it's not. So that's Ollie, and that's Colin. Not the same, but at baseline, needing support to sit up, choreatic movements. You can't really sit still. You could say dyskinetic too. Could they be dyskinetic and choreatic? Possibly. I mean, ask neurologists. We can slice and dice movement disorders about 6 ways for one patient. Is it chorea? Is it dystonic chorea? But the videos kind of give them a nice highlight of how they look. So for Oliver, in 2018 is when the family let me do some testing anew. And so I did whole exome sequencing with a trio, meaning that the parents were tested as well. And we found that he had a FOXG1 mutation. The FOXG1 is on chromosome 14. It can be associated with autosomal dominant mutations that cause encephalopathic delayed movement disorder seizure state. And he had a pathogenic frame shift that was de novo. And my other patient, Colin, when they let me do whole exome the CP gene panel, not the whole exome sequencing. It's a whole different talk to kind of talk about kind of which test is right for which indication, but he also had FOXG1 mutation and had a pathogenic premature translational stop signal leading to nonsense mediated decay. Two very different patients, two very different paths to diagnosis, and they actually highlight nicely, I feel, sort of what could be done in the old days versus what can be done nowadays. And they both sort of lived through a time of revolution, but one lived a much longer time. And they're both still doing well. They're both, one's in a group home now, one's at home with his parents, but very fascinating cases, both of them. The time from diagnosis for my first meeting for Ollie was 9 years, and for Colin was 1 year. And I continue to hope that for everybody, this length shortens and shortens and shortens as science gets better and the tests get cheaper. Although it's a little bit out of our hands because we often are fighting insurance as well. I'd like to give another sort of out of the box sort of cerebral palsy thought, which is LJ, or Lindsay's a girl that I saw when she was 30, she was diagnosed with cerebral palsy as well. This patient as well in my adult clinic, when I began to dig into it, she's pretty much uncomplicated pregnancy, nothing really of concern there. Early development was nothing that bad. She's just always very clumsy. She had problems holding a pencil. They thought she was kind of this merely dyskinetic, kind of ataxic CP, she was called early. And then she actually graduated high school, went to technical college for 1 year, and she transferred to a 4-year college. While in college, she was walking and she suddenly, her legs spasmed and she fell around age 20. And after age 20, she couldn't walk independently. So I think this is called cerebral palsy. She was followed in our clinic. And our very astute and smart rehab medicine doc said, could you take a look at her? Because it's just something seems off. And at age 22, she came to one of our spasticity clinics to seek an evaluation. That's when it was really sent to our clinic too. Our complex movement disorder clinic that we see mostly is just really out of the box, really unique movements. Like they don't really fit into any path, and we love seeing those patients. So like with the previous patients, I'd like to kind of show Lindsay here too. So this is Lindsay at age 22. And we are grateful and thankful to have a gait lab that is outstanding, led by Dr. Georgiadis and Dr. Novacek at Gillette, because gait labs are not easy to come by nowadays, but they have immense value for many reasons. And so we jumped from Lindsay at age 22 to when I saw her down the road. It's a dramatic difference in her gait. From walking independently, this is just before she kind of lost some of that ambulation, to now she's up on her toes. She is hypokinetic. She's moving very slow. You can't see her neck, but she is very dystonic. Her neck is pulled over to her right shoulder. She has a pillow because if the pillow's not there, she actually had an open wound that was between her head and her neck. And so, typical cerebral palsy, right? It just suddenly advanced rapidly in her 20s. Don't think so. So decided to update the evaluation and update the workup. So we did an MRI. She definitely had some spinal changes in cervical spine, maybe a tiny syrinx, but that doesn't really explain this. Did a chromosomal microarray, a limited karyotype. This is the basic screening test. It looks at kind of like if you're reading a dictionary, it kind of looks at maybe a couple letters on each page, rather than like looking at every letter on every page and every word. And so then we did whole exome sequencing, which actually sequences all 20-ish thousand genes that make us up. And we found that she had a mutation in the GLB1 gene. So this is a chromosome 3 related gene. And this condition is associated with making an enzyme called beta-galactosidase that works in lysosomes to break down and recycle different types of molecules. If it's not working, essentially it doesn't break down garbage in the cells. The garbage doesn't take out. If the garbage overwhelms the cells and fills up without being taken out, the cells die. And the disease is progressive. There's a young form that can be really early, but the juvenile form can be associated with gait disturbances, cardiomyopathy, worsening spasticity, and also kyphosis. If you have enough residual, if there's enough enzyme working there that's made by this gene, you might manifest later, like Lindsay did. And so if I try to make this into English or picture form, instead of like a normal healthy neuron, in these cells, the nerve gets overwhelmed by all the garbage products and then eventually dies. And in our patient, this is her brain scan, you actually can see, for those that aren't looking at lots of MRIs, this is a T2 image. The brain is gray, the fluid the brain floats in is white, and there's more space than there should be for a 30-year-old. So there's a little bit of brain atrophy globally. You could say it's a little more focally present on the right posterior occiput, maybe the frontal lobes a bit, but might just be a slice issue. But the ventricles are a little bit bigger on the left compared to the right too. But the bottom line is she has a metabolic syndrome. It was slowly progressive related to this GLB1 gene mutation, and also called GM1 gangliosidosis. So if we look at her over time, puts it all together with a 22-year-old, 31-year-old, and 34-year-old. She's a little bit slower even on the 34-year-old picture. And the astute observer will also see that her neck is not quite as tilted either. That's because we put a deep brain stimulator in and actually was able to help with some of the dystonia. She got her head off her shoulder, but by that point, there's a lot of fibrosis in her neck. So we actually had a neurosurgeon go in and do some really delicate dissection, delicate kind of slices of strictures, and we're able to kind of straighten her head out a bit more too. And so part of this is DBS plus some of the neurosurgical interventions of her neck. For her, DBS is more of a palliative procedure. There has been some reports of DBS in this, and it's been very helpful for her for pain issues more than movement issues. She does look slower on the left, and we made some medication changes over time too, so it's hard to know what's disease progression, what the medication changes are, but the point of this is just the video is highlighting kind of her progress over time. I'm going to show one last patient video as well, and before I kind of get back to the sort of more discussion of literature and my thoughts about cerebral palsy, because I'm a neurologist and I should get to the point, right? Get to the point, what does a neurologist see cerebral palsy as to him? But I want to set the stage of what the history is, how things are getting complicated as we move forward with understanding more about genetics and what the etiologies are. And so I just want to do one last patient presentation as well. So I'll use this patient. This is my patient, SW. And he is a 9-year-old I saw for cerebral palsy with mixed tone, hypotonia, dystonia, and a diplegic pattern spasticity. He's pretty delayed too. He cannot talk, and he's dependent for all EDLs. In Minnesota, where I practice, we have a large population of currently both Hmong and Karen, it's spelled like K-A-R-E-N, Karen refugees, and he's a Karen refugee. Both the Hmong and the Karen were allies during the Vietnam War, and the U.S. sort of left them high and dry. And so they ended up going to Thailand to survive. Otherwise, they would be persecuted by the Viet Cong. And we slowly helped bring many over to Minnesota so that it can start anew here. And SW is one of those patients. Never crawled, never sat, never ate fully by mouth, G-tube, recurrent staring episodes, normal MRI, ZEG looks fine. These are not seizures as well. And I've done microwave and whole exome sequencing, and they are normal. So this is another example I want to highlight too, which is this boy has something. I don't know what it is yet. And when I go down the path with a lot of these families, I always coach them up front that we may dig deep, we might find nothing about a third of the time. And so we're just waiting for science to get better. And 15 years ago, if you look at the workup for these kids, we might have got an answer 30, 40% of the time. We're getting up to like 60, 70% of the time now, but we still got that last third-ish. We're still not getting answers yet. And as science gets better, as we get smarter, we will find it at some point. Whether it's treatable, don't know. I always like to do the genetic hunt because some conditions are associated with kidney issues, heart issues, cancer issues. And so a genetic diagnosis may explain things, but it also may inform our surveillance moving forward too. That's kind of a complicated point that's beyond the scope of the discussion today. But a lot of families say, well, we're not gonna be able to fix it. I'm like, I know, but what about my kid with low syndrome, where we know they could be at risk for kidney failure, and then they also look like a CP kid, and then if we know they're going into kidney failure, we can help treat their kidney failure before it causes anemia and probably severe risk for harm. So lots of reasons why we do genetic testing, and it's our job as clinicians to make sure we explain to families the kind of complicated reality of this genetic testing. So we talked about the history, we talked about the confusions of cerebral palsy or the mimics, whatever you want to call it. And so we're struggling as neurologists kind of like, so should we come up with something other label for these things that look like CP? And there's a really great paper that was published in 2019, and there's others that talk about this, that they say, should we really change the diagnosis thing? And I like this paper because it makes points that I agree with. Heaven forbid I have an opinion that I like, but they really spoke to me, and I really like what they wrote. And the question they made was, the sort of point was, no, we shouldn't change it, even with things becoming more complicated, even with becoming more aware of genetic issues. If we change the diagnosis, this will harm CP registries. There's probably a lot of kids in the registries that have genetic issues that haven't been clarified yet. Taking out patients could lead to false conclusions about interventions. And some of the interventions might help genetic kids as well. Surveillance in CP clinics will help these kids. You can't go wrong giving kids more therapies and interventions earlier in life. Like, if these kids come to a CP clinic, they're still going to benefit, even if they have a genetic driving of this unique neurologic function that's going to help them with PT, OT, speech, adaptive interventions, adaptive equipment. So like the CP clinics are built to help the kids with neurologic function because CP is neurologic function. We can argue over the etiology, but the solution oftentimes is the same, or the offers are the same. We don't want to get rid of developmental services. We have a problem right now. I'll make this point again, where in the States, IEPs and services are built on diagnoses, and there's a lot of confusion about like genetic labels. I mean, someone looks like CP, they say CP, and this is actually happening in the autism community as well. Lots of roads lead to autism as well, and so it's easier to say CP, autism, rather than the genetic mutation that is causing the other labels that come up. And good. Really, with our definitions in ACPDM and child neurology, like really CP is a descriptive term, not really an etiology anyway. So CP is clear. And I think that CP makes more sense than genetic mutations. Like, if I say someone's got a TUB-A1A mutation or COL4A1 mutation, people look at me like, that looks like something you made up eating alphabet soup and things just floated to the top of the soup. Whereas CP kind of makes more sense. It takes a while for new information to catch on the medical arenas, but also in the developmental needs arenas in schools and with insurance companies and therapeutic providers and things like that. So I think, and this paper makes an excellent point that really cerebral palsy is a diagnostic. It's kind of an umbrella term for complex conditions, genetic, environmental, and epigenetic. And I like this point. I agree with this, and I endorse sort of this viewpoint of cerebral palsy. I know this can be controversial. I've been at some of these debates at the American Academy of Cerebral Palsy and other places where we've argued it out, but I just, it's meaningful to get kids services, and this is sometimes this label helps us achieve that end of helping them, even if things are getting more complicated with genetics and more deeper in an understanding. And so we know we talked about the history, we talked about the, typically there's a brain injury, we talked about the confusing nature of genetics. And so I want to kind of focus more now, like, okay, so the diagnosis, I think, we can call things cerebral palsy, but really what is our focus in cerebral palsy as we talk about therapeutics? Because I think the mutual goal, and I like to voice it like this, because I am a conduit for helping families and helping patients, whether they're an adult or a child, meet their optimal potential, because that is my goal. My goal is diagnosis so much as it trends towards, can we get the services you need? And so when I think about the mutual goal of cerebral palsy, I think that CP is a term that helps us recognize if someone has neurologic dysfunction starting early in life, independent of the actual cause. I think that we can argue about definitions till we get blue in the face, and a term is important for many reasons, but the patient in front of you is the most important thing. Everybody I see is an N of one. I have lots of ideas about how we can help everybody, but when I enter a room to see a patient, I usually do not end up where I thought I was going to end up. So I always go in open-minded to listen closely and figure out what the needs are today. And this is a talk that's for everyone. But I will say, when we think about typical CP, I'm proud of my institution in the sense that we have done things like make a roadmap. And even though we think about typical cerebral palsy as not progressive brain lesion, again, it gets complicated because there's some genetic kids hiding in there where they might progress a bit. I like the fact that we did make a roadmap for, depending on which level of impairment they have, we sort of tried to suss out for people what their needs were at different ages. And I meant this to be so small that you can't read it. Because what I'm saying here is that we have begun to kind of dig into different kids have different needs at different ages as they grow. Even in the brain lesion kids that aren't progressive, Boy, it sure looks like they progress, because suddenly when they grow 6 inches, they're more tilted. The scoliosis progresses. Their hip might dislocate more than it was. So, and not to mention everything else that happens too. So it's not just the brain, it's all the brain downstream impacts where the tone issues from the brain drive orthopedic deformities. Could the autonomic dysfunction with thalamic injury drive some other issues like long QT syndrome with cardiac function or bowel dysfunction? I mean, the neurologic complications drive a lot, and so it does change naturally over time. So maybe not progressive, but boy, it can look different. And so if we really look at the paradigm of how do we treat each patient individually, how I think about this and how I think about our goal is, if we think about a child first, I'm going to talk about adults too, because I want to make sure we don't forget adults, because these kids become adults. And there's an army of adults with cerebral palsy out there living. So things might change differently at different ages. So maybe for a young child, their major needs are at that point social support, school, and therapies. For a very mild diplegic, mostly legs impaired, what I mostly care about is, are the social determinants of health met? Like, is the family able to get to appointments? Do they have resources to get the therapies they need privately? Is the school meeting their IEP needs? And are they able to these are the bedrock. And for every family I meet, the most important people for any patient that I meet is the family, number one. Number two is the school. And number 3 or 4 is the medical team. And I tell families this very overtly, because I need the families to be the best advocate, because everybody else, I'm like a guest star on the Love Boat. I'm dating myself. I show up maybe every couple seasons or every once in a while, but like the family's there every day, getting the kids up, changing diapers, getting them bathed, getting them out the door. So I mean, I give a lot of respect to the families for that, and everything else kind of is a little bit secondary, if not third. But the child, so these are the major needs a child might have, but we can't also forget the other things like nutrition and mental health and pain. And I put the medical team overall, because at different ages, they might need different providers more, whether it's orthopedics and PM&R, maybe it's sleep medicine as they get to puberty or earlier, maybe it's neurology, pediatrics, neurosurgery. To be fair, there's kids I meet, I walk in the room and I say, how are you doing? The parents look half-mast eyes, and I'm like, well, how's the sleep going? They say, haven't slept in weeks. Like, okay, that's issue number one for me. Let's focus on that, because sleep is the foundation of good neurologic health. You sleep better, you learn better, you have less seizures if you have epilepsy. And so I could make this map up, and I do mentally make this map up for everybody very differently as well. And if we think about an adult, their main core needs might be different. It could be social support. They may live at home. They may live in group homes. They may live with relatives. Mental health needs in my adult population is intense. And I begin to talk about mental health even in my 6, 7, 8-year-old patients, because before puberty hits, if we see some compulsions, we see things, when puberty hits, it's going to get that much bigger. In my adult population, quality of life, depression, a lot of compulsions, and sort of this chronic stress they live with, because people are always looking at them. If they might be wicked smart and have a PhD in social work, but people see them moving with the crutches and they assume instantly there's something unique about them. So they live with chronic kind of trauma of how society views them. And so the mental health needs are huge. Pain in adults. For some reason, even the most tight kids we see early on don't typically have a ton of pain. And this is controversial, because we are digging into this. I think they have more pain than we realize. It's just they're so used to chronic pain, they don't identify it like others do. But in the adult population, we see more pain creeping in the 20s, and that's a huge issue for a lot of our adults. And that's why I think I'm very happy, like a lot of states have had cannabis laws, because actually cannabis has helped us with that. And I'm not here to endorse that. I'm just saying I've used it a lot in my experience. And so, but they also have other needs too, and it can get complicated with the therapies, and they fall by the wayside. Once the kids hit 22, they're out of school, they do tend to lose function because they lose therapeutic access to schools and IEPs. Nutrition, communication, school, and maybe in the adults more, we're worried about PM&R, neurology, and certainly neurosurgery, because the adults do age differently. And so as a CP neurologist, I'm thinking about all these things, but let me get back in my lane, because I'm talking about the patient and their needs. And if I get back in my lane as the neurologist, what do I think about for the kids and adults overall? And for that, I'm going to do one slide, and I could give numbers to these. I could dig into, in the Australian registry, this is the percentage that have epilepsy, this and that, but I like percentages, I like all that stuff, but each patient is either 0 or 100%. So instead, I think in big categories. So when I think about, as a CP neurologist and the patients I see, I think about the diagnostics. Did they get the workup they deserve? Do they have something genetic that we need to be worried about? Give an example. I have a Cole 4A1 patient that looks like a hemiplegic. He had a unilateral stroke, and they did genetic testing on him. And that was my younger years. I was like, he's not genetic. He's just typical CAP. Boy, was I schooled. And I get schooled a lot every time I have pride and think I know something. That he actually had this genetic mutation, can be associated with further strokes, cataracts, and also cramps, and also maybe some cardiac issues. So knowing that about him, he looked like a simple hemiplegia. He was not. It changed my approach to him, and it schooled me to make sure that I never get close-minded about he might be missing something, Tim. Also with imaging too. It's good to confirm things with imaging. If it's a patient that hasn't had good imaging, we should do it, because we do find other things, whether it's brain malformations, schizencephaly, whether it's, I found a couple times where there's emerging or enlarging cysts, and the way we find like a Chiari that needs intervention, or actually I had one child that looked like cerebral palsy, and they had a large expansile spinal cyst, and they actually needed to have it marsupialized and sort of opened up so that they weren't causing more damage. I think about the cognition, development, and mental health. I think that one of two things that are most important for kids and adults to see their potential is good learning. And so I'm always focused on, can we do some neuropsych testing? Are we make sure they're meeting their educational needs? What can we do to foster that? And mental health as well, because a lot of my teen parents, mental health becomes issue number one. I mean, they got the walker, they get to school, they got tone management, but it's the compulsions, the OCD behaviors, anxieties. I mean, that can really take a kid off track and an adult. So we need to make sure we're paying attention to that, because tone doesn't matter so much if a child can't leave the room because they're too scared of the world. I think about orthopedics. It probably would be run out of Gillette with pitchforks if I didn't talk about orthopedics at Gillette. But I think that the brain tone changes can drive orthopedic abnormalities. With spasticity, we think about hip issues, scoliosis. More of the pure dystonics don't tend to have a lot of hip issues. We published on that. Dr. Gomi did specifically here, but the tone issues can drive orthopedic abnormalities, and if they're not well managed, it can harvest or impair mobility, and or could cause pain down the way. So I think about that a lot. I think about sleep. When I've heard Jean-Pierre Lynn speak from London, he's one of movement disorder, a neurosurgeon, but he always talks about the two most important things are good education, good sleep. So sleep is the foundation of good neurologic health. We try to attack as much as we can. I mean, to be fair, most of us know that as parents, those of us who are parents, because it's like when you're sleep deprived, I can't remember anything in their first couple months of life. And hopefully we all find that good sleep for our kids, for ourselves, and actually caregiver fatigue that don't sleep. I try to help that secondarily to the kids' sleep as well. Think about autonomic dysfunction. And I think that this is such a huge topic. It's hard to put words around it. Autonomic is the automatic nervous system. It's kind of maintains our homeostasis. If I put a thermometer on my finger, it goes 98.6, 98.9, 98.4. My body keeps my temperature pretty even keeled, but the automatic autopilot stuff for our kids with cerebral palsy is off. They don't sweat, they sweat too much. They have high temps, they have low temps. A patient this week in the hospital where we just randomly dropped their temps to 89 degrees Fahrenheit. And so we're struggling to figure out why this is happening and kind of what we can do to help them. But GI motility is a big issue with autonomic dysfunction. When we get nervous, we get gassy. So the brain and emotions through the autonomic nervous system has a lot of input into the bowels. A lot of our CP kids have a lot of issues with bowel dysfunction. And honestly, 80%, don't quote me on that. 34% of the time when I see severe agitation in kids, it's usually kind of bowel dysfunction and constipation. And actually in our teenage kids, as they get older, they get neurogenic bladders that worsen. Sometimes they need a better bladder management as well, because they just distend their bladder but don't fully empty. I think about tone. Whether it's dystonic tone, we try to approach with meds, or spastic tone, we approach with meds and or Botox, or both for that dystonia as well. And for our really involved high GMFCS levels, we're talking about sometimes surgeries or whether trisotomies or back on pumps, or you get the point. And we try to help for the really unique dystonics. We try to control the tone before we recommend a lot of orthopedic surgeries, because otherwise dystonia sometimes will re-deform if the corrections are made. I think about therapeutic resources, community supports. Again, in some ways they're more important than us. I really worry about the caregiver and environment. The foundation for these kids' well-being overall. Their sleep is important, their education is important, but it's the families and their well-being as well. And I'd like to dig into the one last issue too, which can be kind of challenging as well, which is epilepsy. And I bring this up because I do care for a large proportion of kids with epilepsy that have cerebral palsy. And so when you begin to sort of dig into that population, which in my clinic is probably like 60 or 70% of my CP patients, because that's just, they're overrepresented because they need be. I have to think long and hard about how I treat them, because if we're not careful, a lot of epilepsy meds can also cause issues. And I should add, epilepsy can suddenly get really bad and cause pseudoregression. So kids get really bad seizures, they regress, you treat the seizures better, they come back. But in this quest to kind of find the perfect epilepsy med, I like to show this picture, which is from a neuropsychologist I used to work with. And she published this back in 2000. There was a patient where in the spring of 2000, this patient came to see her. And this is a child with a genetic disorder. So this is not the same as cerebral palsy, but it's going to still illustrate my point nicely. And so the spring of 2000, she comes to see my colleague. Beautiful picture. This is the ocean with dolphins and fish and the island and fishermen. And so some med changes were made for epilepsy. They put the child on zonisamide or Zonegran. I'm not picking this one med. Some meds go really well, some kids don't. And so when the later when this child came back, and they said, "Oh, you drew me that beautiful picture. Can you draw me another picture?" And by the fall of 2000, this is the same kid. So in some of the testing, the parents said the kid's doing fine. Seizures are better. The seizures are better, but sometimes we don't always fully understand the way that some of our medications can impact the thought processes. And I love this, and I show this a lot because, especially when I teach residents, because I'm just like, it's just a reality that we may unintentionally cause a lot of issues. And some of the epilepsy meds, and just any meds, not just epilepsy meds, can have a lot of unintended consequences for the well-being and thought processes that we may not fully capture just asking parents or even doing things. So I like to have kids draw pictures because I'm always curious to see if I can capture something as dramatic as this, but I haven't yet. Actually, there's good literature to show that drawing pictures of headaches actually helps with diagnoses, but that's a whole different issue. Forgive me 1 second here. I think that I'd like to even focus a little bit more too on, it's important too that I think about what patients need. I think about what diagnostics they need. But it's also important to focus on what CP patients say they need. It took medicine a long time, sometimes do the patient questionnaires to ask patients like, what do you need to be healthy? What do you need to be happy? What do you need to be, your best self? And I think that there was a really excellent paper in 2021. They looked at 23 adults aged 23 to 47 with all GMFCS levels, well, up to 4, to kind of ask how they negotiated challenges with adulthood. And this is just kind of food for thought. Not so much that I have a clear point on this, but adults with CP are happiest when they get to do what others are doing. Duh. I mean, I feel like I'm glad I studied this, and there's certain things I present to parents. I'm like, it's good to sleep. Duh. So it makes sense that they want to do what everybody else is doing. They all do well if they had typical parental expectations and people didn't completely bubble wrap them and expect less from them. They like to be they like to have good expectations. I mean, obviously, this is a bit of a balance because we can't expect someone who is a GMFCS4 to walk, but I mean, you get the point. Like, how do we actually optimize expectations for them? And, trying to make sure we can help them to find ways to negotiate challenges. I won't dig into this too much because I want to make sure I'm mindful of time. And then also, just gravitating towards those who are comfortable with difference, maintaining function using natural and paid supports. There's just a lot of things that we can do to better understand and better help an adult be the best. And this paper had a really nice graphic that I'll just splash up there for a second, because actually I think we as providers need to acknowledge that many of our patients become adults. And so I often think of in my 5-year-old CP patient, I'm laying the groundwork for a 25-year-old CP patient. And how do we help coach the families early? I'll give you an example. I just saw one of my 21-year-olds who just started college. She is a very mild diplegic, but she's got some cognitive issues. She's pretty high functioning. She is in college now, and the college has not been following her IEP. Now, her mother started writing into her IEP around age 12 or 13 self-advocacy goals. And so this girl who's now in college, she's been taught to self-advocate from an early age. And now in college, she actually has been able to drag in some resources. She needs some help. She got some friends, but she is able to go and meet with the representatives at school and self-advocate for her with some people kind of helping her as supports. But she has been able to self-advocate for herself. And that whole process is actually, instead of being negative for her, it's been positive because she is advocating, they're listening, they're making adaptations, and she's doing it herself. She's not being spoon-fed that, and her family's been working on that for a long time. So how do we help all that are capable of that reach their optimal self-advocacy potential? And also, we're learning with CP, another excellent paper with many authors who might be here. And certainly one of the authors is Dr. Kroc, who is at Gillette as well. They looked at kind of adults with cerebral palsy and some other issues. Oops, my bad. That they do have higher rates of lots of things, like increased risk of stroke, increased risk of myelopathy. And oftentimes their tone drives changes in their spinal cord, and they can pinch their spinal cord. Loss of mobility earlier, chronic fatigue, chronic pain. This actually looked at things like epilepsy and dementia, so it's bigger than this. I just wanted to throw up the graphic that I thought was nice to kind of borrow. But we need adult neurology providers and adult providers that can sort of be understanding that the disease course can be different than a typical adult who doesn't have cerebral palsy. I think it's important to be mindful of unexpected changes. Things may change unexpectedly, and we have to be hopefully help them because some are treatable. And the case I showed earlier of LJ, who had the GLB1 gene mutation or GM1 gangliosidosis, which is a good example of someone who, she did have some pinching of her neck. I mean, it was pretty clear from her neck tilt with the pillow, but even then, I've seen a few others that have a little bit of retrocollis or extension of the neck, and we do a spine scan, and they have pretty significant cervical stenosis that we're worried about that we need to manage too. So it doesn't always smack you in the face. Sometimes it's real subtle. So I hope there's been enough focus here for everybody to get something from this, because we've covered a lot of topics, and in a lot of ways, a lot of these topics, each one in and of themselves, could be a whole talk. But so I'm trying to make the conclusion that CP is an umbrella term at present, but I think it's a useful term. And really, does the definition matter beyond services and research? I mean, not so much. I mean, it'd be nice to separate things out, and a lot of the gene conditions will probably get sequestered into their specific gene therapy or gene specific sort of cohorts for research over time, but all the patients can benefit. And I think what's most important for cerebral palsy as a neurologist is that we really focus on the individual and the disease. We understand the reason for neurologic dysfunction and its impact in shaping the game plan for individuals' well-being. And so it's hard. It's really hard. It is hard to individualize care, and it's the right thing to do. So I am exhausted at the end of clinics often, and it's a good exhaustion because I'm doing the right thing. I'm meeting the patients. I'm listening carefully. I'm seeing what their needs are. I'm trying to meet their needs, knowing that I can't perfect it for everybody depending on their social constructs. There's a lot that goes into that. But I think it's important to focus too, though, like there's been times in my career at Gillette, before I get to the selection slide, is, we see these kids that get, Botox for 18 years and wheelchairs and meds and this. And I think that, I've had the great opportunity to really think to myself, does this all matter? And I'm a reductionist because I'm always wondering every day, I ask myself, am I doing good? Does this matter? And I think that, had the joy and benefit of being able to kind of do work in other countries. And I'll highlight one experience of that because I think that I had the fortune to kind of go to Jamaica a few times with Dr. Dawson down there. She's kind of University of West Indies in private practice at Bustamante. We've been able to kind of see some of the kids down there that, actually, I think this is the trip many years ago where Hank Chambers came with us from San Diego. But I've had the opportunity to see some of the kids down there and adults where nothing has been done or not significant benefits been done for them. And to see how much worse their deformities are, how much worse their pain is, just the chronic care for these patients matters a lot. It makes a huge difference. I'm grateful when we can go and teach locals. And again, there's a great pool database in Jamaica. There's a lot of local providers that are experts, but the need is intense. The resources are poor. And, living in a resource-rich country, it's easy for us to take it for granted sometimes, the fact that it's not normal. But with that, taking this weird kind of a detour at the end, I'm going to stop talking because I want to take a drink of my tea and get rid of my vocal fry here. But with that, I'm happy to open the floor to questions. I'll unshare my screen, and I really appreciate everybody taking time out of their busy schedules and lives to listen to me talk at the camera on my computer for a bit. So thank you.
There we go. All right. Thank you, Dr. Feyma. That was amazing, actually. So we do have a lot of questions in the chat or in the Q&A, I'm sorry. So I'll start with a few of the second one, actually, because it combines with one of our last questions. And I think it's a burning question that we get often. And you recognized it a little bit in your talk, and that was that as children, there are services available for those with cerebral palsy. But as you know, they become adults, it seems like nothing is available. And they want to know, they're asking, is that the case for the majority of adults? Is that's what to be expected for children as they age?
That's a sad truth.
Yeah.
I think once the school funding ends, I used to believe that the hardest part for a lot of the kids I care for and adults I care for was puberty. And I don't believe that anymore. I believe that the hardest part is the early 20s. A lot of resources fall away. A lot of parents get busy trying to problem solve. What does my child do during the day? I have families that live in rural Iowa, and the kid sits at home and watches TV while mom and dad go to work. I mean, it's tough, and we live in times of shrinking benefits and services. So Republican or Democrat, I testify at the state in Minnesota sometimes, they're both cutting funding for young kids. I won't get political. I think I don't like both sides of the rail when it comes to this. I think because I'm pro-child and pro-special needs adult, and I share it a lot, but I don't say what it is, but I'm also a special needs parent myself. So my passion sometimes gets a little bit over and above because I get really, I see my 11-year-old becoming a 22-year-old and I wonder what I'm going to do. So it's a sad truth. The services fall by the wayside. It's tough. I mean, I get an episode of care. Like if I get a 30-year-old, I might get maybe a couple visits of therapy, but they usually don't get the chronic therapies like a kid gets. So I'm sorry, Valerie, I don't have a perfect answer for that.
So I do have a question to attach to that. Is I know Gillette's at times will serve adults. I think you already referenced it. And I think there are a few other hospitals that will continue to do that, recognizing the problem. Is that correct? I'm
very blessed to work at Gillette where we can see adults, but I think the social determinants of health, some of the community supports that fall by the wayside are the bigger issue. The special needs community is very diverse. There are some kids and adults that can go to a day program that they like or work projects, and there's other but that is a big pool of people. And there's some of my patients that are very high functioning and they go there and it's very low functioning patients. I'm not casting shade at anybody. I'm just saying that there's strata of abilities in the special needs community, and that's not recognized in any adult programs that I've seen so far. And so we have a crisis in this country with this, and I don't have a simple way to solve that.
Yeah, I would agree. Question from Lee. He said, I've heard the phrase variation of unknown significance, or VUS. What is that? What is the significance of that? And do we all have VUS?
Great question. Variant of unknown significance is just, we don't know. There's complicated prediction models that will actually, computers that will crunch the numbers on these things. And they'll say like, is this important? Does it make the right protein product? And I could dig into that. Actually, Michael Kruger should give a talk on that. He's an expert in that. But I think that he probably has given a talk on that, to be fair. Probably many talks on that to various communities. But we're still learning a lot. We're still discovering innovation. So we find some of that. If it looks really suspicious, then we'll do parental testing if we can to see if it's inherited. And there are even more complicated tests they do now where they can clone the gene and see if it makes the protein product and actually transcriptomics and things like that. But it's a really rapidly evolving field. The smarter we get, the more complicated the questions get. So I hope that's a good answer.
Yeah, well, that's the truth right there. And to your point about Michael Kruger needing to do a presentation, he has done one for the professional learning series, but since he is the co-chair for the research council here at UCP, we have him on a short cord, and we'll get him to do it for 2025. I was actually thinking of that as well too, because so much has changed even in the last year. Our understanding has just grown astronomically through genetics regards to cerebral palsy. So yes, we need to bring Michael on for sure. So this is another question. It sounds like they have a patient with COL. Oops, it just moved on me. COL 4A1. Am I saying that right?
Yeah.
Would you say that's hemiplegic cerebral palsy due to the mutation, or okay, due to COL 4A1 or CP and COL 4A1?
Boy, I'm glad that my esoteric mention hit somebody. Yeah, and I'd say cerebral palsy, and I'd be aware of the genetic kind of, just kind of all the complications that can happen in that disease. Yeah, my Col 4A1 patient that I followed forever, one of them just passed away from epilepsy, and so he schooled me in many, many ways, and it was kind of tough, but we don't need to talk about that. So I call it cerebral palsy, and just note that if you go to the school and say, hey, they need their IEP because they got a Col 4A1 gene mutation, they'll look at you like, is it CP or not? It's like, yeah, CP. So that's my bias. I could be wrong.
Okay, so they're adding to this. Similarly, if a progressive genetic condition missed early on, would you take CP diagnosis off?
I don't like to take diagnoses off. That's just me. And I've had, beyond CP, I see a lot of kids that have been diagnosed with autism or this or that, and we find new information. And I just, it's my bias not to take diagnoses off. But I could be wrong.
I heard you speak about the resources that are attached to that diagnosis, and I think that's really something we have to think about deeply when we come to these, junctures. So, another question. I've heard no spasticity, so no CP. Your thoughts?
Don't agree. I'll be definite on that. I think that I have kids that a term hypoxic, where they have just basal ganglia injury, because that's the kind of the watershed area of the brain that's really vulnerable to blood flow. So I've seen kids that are purely dystonic. They're pretty rare. Again, I don't agree, but I also am empathetic to those that say that, because I trained in a place that said that. And to be fair, that was my elders. And so as we get smarter, we know more, we probably change the definitions a bit. But yeah, it could be dystonic, it could be aphatoid, and then I think hypotonic is the one I most sort of like wince at, but I've used it before, because if you do all the genetic testing and a patient looks genetic, a third of the time you don't get a genetic diagnosis. So I have kids hypotonic CP, because that'll get them the services, because at some point around the IEP, around age 5 or 6 in the States, if you don't have a better diagnosis, you lose some of your services. And so I've been to that as a parent. I'm the child special educator. I have a lot of thoughts about services in schools.
Yeah. So the next question is, what do you think about dysautonomia? Oh, you know what? I don't even know if I can pronounce this. I don't know this term. So what do you think about dysautonomia? Oh, dysautonomia. I don't know why my tongue will just wrap around that, but my client is severely affected in every system. Dysautonomia.
It's okay. It's dysautonomia. And this goes back to autonomic dysfunction, and that can change over time. So the spiel I give in clinic is we all have the autonomic nervous system. If I get embarrassed, I blush. So my brain and emotions have input in my blood vessels in my cheeks. If I get nervous, I can get gassy. My brain and emotions have input in my bowels. And if I think about exercising, my heart rate goes up by 40 beats a minute, because my brain says, "Come on, pump, get going. We're gonna need some blood to run." So this stuff is autopilot, and it connects to all this stuff. But in kids with cerebral palsy with brain injury, they may have some autonomic dysfunction, and so it's unpredictable. They might have high or low heart rates. They might sweat. They might not sweat. They might have high or low temps. They might have one ear that gets flushed when they get upset. What I most often hear is when kids have to poop or pee or void, you'll see them kind of get ramped up with movements and also kind of get flushed and stuff. And so it can come in 40 flavors or more. And actually, the autonomic nervous system also lets out like adrenaline from our adrenal glands. That's what a panic attack is. So I have some kids that it's like the physiologic base of panic attack. They get these spells where they're like ramped up and hot, and they're agitated for 40 minutes. And some of them have high cortisol levels. So I'm just like, but there's a little bit of a hand wave with all this too, because we can't always do perfect testing for it. So I would say that probably dysautonomia, watch out most for the bowel issues. The bladder issues, I have a lot of like 16, 17-year-olds that are nonverbal, and they have had like neurogenic bladders that get worse. So they come in 16, 17, they're having these pain behaviors. When we scan their bladder post-void, they're not emptying. And so then we do find that, there's all kinds of crazy stuff going on with that, but it's hard to present because it's so variable. Anyways.
So another question, and it's related to vision. So you haven't commented on the issues related to vision or hearing. So we know we see a high incidence of cortical cerebral visual impairment in children with the diagnosis of cerebral palsy. So I think Sarah wants you to comment on that for us.
So vision and hearing, absolutely. I see more vision than I see hearing issues, but they're both. I think that when I think about the neurology of vision, cortical visual impairment just means there's something from behind the eyes back. And so cortical visual impairment is tough too, because it can come in like a lot of flavors. And the hearing issues can come in a lot of flavors too. And testing for them is tough because, we can sedate a child, give a little click in their ear and see what goes on, but it doesn't tell us how they translate that sound, because the sound gets in, but then is it translated into voice like I'm talking now? Or how do they hear that? We typically just tell if the nerves are working. Yes, very high rate. I see, I don't want to say very high rates. I want to say I do see a lot of cortical visual impairment in hearing. And I do test for it a lot. It's always hard to know what I always do with that. It's some of my less verbal patients. The more verbal patients, sometimes we can do more and kind of understand, but this gets to a bigger discussion of the less verbal or less communicative patients. How do we help them best? But it's there. I agree. It's there. I didn't comment on that, so I apologize.
Okay, so another question, do you recommend, this is back to the genetics, do you recommend genetic testing in all CP diagnosis, or is there a certain population? And then along with that, what age do you initiate genetic testing if it is only a certain population of kids with delays?
Oofta.
You want me to say the first one first again?
No, I got it. I'm ooftaing. That's a very Minnesota expression. I'm ooftaing at. That's a tough question. And I recommend genetic testing when something doesn't seem right. So let me give you some scope. So we run a motor delay clinic at Gillette, and we actually pulled the data for a year because the motor delay clinic we had was really meant to kind of capture some of the cerebral palsy kids. And we pulled the data for a year. Only about 13% got diagnosed with cerebral palsy. The rest had some genetic stuff and other stuff, and some kids actually normalized. It's good. Sometimes kids are slow to develop. They're not walking at 60 months, but suddenly at 18 months, man, their language is on track, everything's on track. It's usually a boy. That's just the way it is. They tend to be a little more pokey than girls, and there's data to back that up. But I think, I tend to not genetic test everybody, but I think about it in everybody. If it's a really clear story, then maybe not. But I don't know. Over time, I more and more recommend genetic testing. So my answer to that's evolving. So not everybody, if it's a really clear story and really matches well, but I also know enough to know that sometimes it's hard to know where the border should be for that. Sorry.
Yeah. Well, I know, and I hear, that it can guide care. So that's the thing that sometimes can be powerful when you're considering that. All right, here's the question. I am a PT who works in a clinic that serves a large CP population. Lately, we've been getting pushback from physicians on getting imaging due to not wanting to expose to radiation. Thoughts on this or suggestions on how to work better with the physicians for the betterment of the patient?
You're in a tough spot because our community is like, I go to rural communities, I won't name where, and they're just like, it's just what it is. I'm like, well, if it's a young kid that's developing uniquely, prove to me it's not a brain tumor. I hate to say that too, because I have found some kids with unique delay. I image them and it's not CP, it's a brain tumor, right? My job is to think about the differential. And so I'm thinking about genetics, I'm thinking about other things. I've had kids with major vascular malformations, like, oh my gosh, if we don't coil that sort of AVN, that sort of aneurysm, like that kid could have a stroke. So I think and some doctors aren't receptive to that. I was going to say don't listen, but saying receptive sounds better. But I think that hopefully they can be receptive. Hopefully they can be open to some education papers or that. But I mean, radiation. I believe the best study is actually an MRI anyways, which is no radiation, so it's just magnetic waves. The challenge of that is you need sedation, so that actually sedation becomes more of the obstacle for families sometimes than the radiation. But even if it was just a CT or a radiation scan, like with spiral CTs, there's a lot of protocols now that really limit the radiation, so it shouldn't be a big concern. But the bigger concern for me in that question is why aren't they digging into why the person's moving uniquely or developing uniquely?
Yeah. Okay, we actually are going to have more questions that we're going to have time. So I'm going to see, is there such a thing as a parent who maybe pushes a kid too much? And we all feel this, right? No matter what, where are the challenges for our children? But I think in this case, if so, how do you address this issue? So this might be a provider trying to help come alongside of a family, maybe. It's the way I take this.
Yeah, I can wear my doctor hat, my parent hat, and I've done it with my daughter. I pushed her to the point where she falls down in tears, and I feel like the world's worst father of all time because I'm just like, okay, but it's a delicate balance of like, there's a ceiling there, but it's kind of glass, and you don't know where that's too much, and so it's always this kind of push and give as a parent. And I do see parents in clinic where like they sometimes early in a diagnosis, a parent thinks that more is going to cure. And I really respect that. As a neurologist that treats all these patients over a long time, I see the journey of trauma. And as a parent of a special needs child, I've lived the journey of trauma. And I have good and bad days like they do. But sometimes I will say to parents early on, and I share some of my story with parents not because it's about me, but it's about, let me help inform you. Like, you are doing everything you can. You are pushing your finances and your time budget to the hilt. And the kid hates it. The kid needs a break. I mean, like sometimes taking a break and coming back, there's like data to support this actually shows that they may slip back a bit, but when you come back, they'll actually slingshot to higher than they were. So sometimes a little break now and again, let them be a kid is good. And I'm on call today. I had one clinic visit today with a mom, and the mom said, you know what? We're taking a break till the fall. And I said, you know what? He's 11. I said, get it. I said, you'll get no shame from me. And she's the kind of parent that did everything and then some, and private therapies and traveling for, like 1 week of intensive therapy in California / Denver / New York. And I have these families that do that. I don't get in their face too much as I just say, like, if you fatigue at some point, it's okay to take a break. So.
Yeah. Yeah, I here in Arizona, we see the same dynamic. It's really hard for our families to know, and there's so much that's being made available, and sometimes those intensives are they're short of a boot camp some days. So.
And if I may add, there's a lot of shaming that goes on from families, like aunties and uncles or whomever. I won't pick like if you just did this, they'd be fine. But there's a lot of internal shaming, and it's like I often when I meet parents, I'm like, you're killing it. Like, you are doing a great job. I mean, are you doing okay? I mean, because like I tell parents, like, you're in the top 8+% of what you're doing. I want you to know that. And so the only thing that gets on my nerves is the parents that don't care, that do nothing, which is a very, very rare occurrence. But most of the parents, I'm like, you are rocking this. Like, this kid is lucky to have you. And most of the parents will tell me, actually, it's my kid is happy, they love it, and not all kids are that happy, but they do it because of the right reasons.
Yeah. I'm going to jump to one other topic. I'm trying to sort of not be super redundant, but I think this will be potentially our last question. Okay, in the high-risk CP infants, do you think an early diagnosis of CP can be made when they are scoring poorly on the GMA and HIND, but have genetic or other causes identified for their delays?
I think this harkens back to the 2017 paper that talked about early diagnosis of cerebral palsy, which I'm aware of. I think they need to have accurate diagnosis. So we've had this discussion internally where, accurate diagnosis is better than early diagnosis. Because what if they need to see a neurologist or someone that can work them up a bit? It doesn't have to be me or neurology, but because what if it is that brain tumor? But if it's a genetic syndrome, that could be associated with something else. So like, if you want to give them CP, give them CP. You can't go wrong doing therapies for these kids. So I'm pro therapy early. I'm also pro accurate diagnosis early as much as we can. And so I think that kind of answers it a bit. So if you want to call them CP, that's fine. Make it a provisional diagnosis. But we have an access issue in the States. I mean, the wait times are not quick anywhere. It's not like, oh yeah, see a neurologist. Oh, yeah, I got time tomorrow. Just come on in. It's like 6 months, or you got to fight for a referral, or you get the point. But so.
What do you think about, okay, so I'm going to just tag on to this. What do you think about the idea of high risk for cerebral palsy?
I like it. I like it as long as it guides intervention early. But we've struggled a lot with this definition internally because we were trying to make a kind of a CP focused intake clinic. And again, when I pulled the data, it's only about 13% got CP. So I was saying this highlights my point that we need to make sure that we're doing accurate diagnosis. I like the term high risk for CP, but if we just think about CP, we're missing the fact that this is a really diverse population. And if we're missing a kid that's got a heart condition early on, like, but access is an issue for genetics, neurologists, human art too. So.
Yeah. All right. I hope that I haven't skipped anything that was. I apologize to those who sent in questions and we haven't been able to answer them all, but I tried to work through them as best we can. This is great. There are a lot of questions I can see, which underscores the struggle of adults getting services. And like we've talked about, that's just really a real thing. So a lot of people are interested also in the sources that you provided on your slides. And I just want to reiterate that this presentation, which it's already been put out there, but this presentation will be on UCP's website. If you go and look to the right of the front page, that's not the right word, but the front page, it's under the research tab, and you can drop down, and under there is professional learning series. So I know that that link has been put into the chats a couple times. So you can definitely find that and be able to watch it again. It might not be up right away, but it will be up soon. The other thing that I did want to remind people, please, again, make sure that we have your full name and your last name. Don't make Josh at Gillette's go on an investigation to try to be able to get you your CMEs. Please make it easy on us so that we can make sure that you attended and we can get that to you. And if you don't, for some reason, get a certificate in the next couple of days, please reach out, because that will also help as well too. I also want to let you know that there is a survey for today's presentation, and we are really asking for your feedback because it helps us just to do better in the different presentation, or each time we do a presentation, we have actually used that feedback regularly. Also, upcoming presentations, we're very excited about the September presentation. Hip surveillance is a hot topic for children with cerebral palsy, and that's presented by Dr. Michael Healy. And then baby constraint-induced movement therapy, the essentials of evaluation and treatment. So actually that's myself and Kelly. And so very much excited about 2025. We're talking to some great speakers. So if you haven't noticed, this presentations usually happen quarterly, so every 3 months. So please, again, fill out the surveys. We're looking forward to your feedback. And thank you, everybody, for attending. And thank you, Dr. Feyma. It was an amazing presentation.
Thank you.
We so appreciate it. Everybody have a good evening.
Thank you.
Bye.